Good afternoon, everyone. Thank you very much for joining us. This is one of our interdisciplinary lecture series, and we are quite excited to be hosting Dr. Khanyo Ngcobo. This is an initiative really that has been led by Department of Psychiatry and Department of Neurosurgery, with the hope that we can try and improve interdisciplinary collaborations and look at how we can work together, those that are interested in the brain. I know that we have neuroscientists on. We should be having, hopefully, there's neurosurgeons and other specialties that are to do with the brain to be joining us today. So I think those that know me know that we are particularly proud of Dr. Ngcobo. And in fact, what she has been exposed to is exactly what we would like to happen for our young people. So Khanyo graduated from here as a registrar and did exceptionally well during a training. And then she started working in psychiatry at King Dinizulu Hospital, and then got this amazing fellowship to go overseas, and she'll be telling us about that experience now. I think the hope for us is that people do spread their wings and they leave Durban for a while and then come back and add to the pool of knowledge and expertise in our department. So we're very happy that Khanyo went overseas and she's back. And so we're looking forward to listening to your experiences, and hopefully you are happy to be back in SA, and looking forward to your talk, Khanyo. Thanks.
Thanks, Prof. Good afternoon, everyone, and thank you for attending. Like Prof said, I'm Khanyo Ngcobo. I'm a psychiatrist and now a Senior Atlantic Fellow for Equity and Brain Health. And this afternoon, I thought I'll just give a brief introduction about dementia, and then I thought a topic that would be nice to discuss would be PTSD, because we see a lot of it in our clinical settings, and the treatment guidelines are not really clear. So just to share some of the data on that. And then I will talk about GBHI, which is the program that Prof is speaking about, that I was a part of and still a part of, and then my personal GBHI journey. So just looking at the prevalence, so it's estimated that there were 2.13 million people living with dementia in sub-Saharan Africa in 2015. And this number is expected to reach 3.48 million by 2030, and then more than double by 2050. So this just speaks to the impact of dementia and the burden. And then when looking at South Africa, in 2014, it was estimated that there were around 730,000 people living with Alzheimer's. And then other research studies show a prevalence between 6 to 12%. But we know that in South Africa, prevalence data is lacking. So the figures that we have here are probably not a true reflection of the disease burden. So when looking at South Africa has the highest proportion of elderly people in the African region, of around 8.6%. And this is projected to increase in the coming future. And when looking at our context, we know that neurodegenerative diseases are prominent, and we also have factors such as HIV. There's also now a higher burden of non-communicable diseases, which are risk factors for dementia. So then this just speaks to that the burden is there, and the burden of dementia is probably going to increase in the coming future, which speaks to the need for interventions and implementing dementia care policies for our population. So just about behavioral and psychological symptoms of dementia. So if we look at the diagnostic criteria, just as a refresher for major neurocognitive disorder, it's evidence of significant cognitive decline from the previous level of performance in one or more of the cognitive domains. And this is based on concern of the individual, the informant or the clinician, and impairment in substantial impairment in cognitive performance. And these deficits interfere with independence in everyday life and everyday activities of the patient. Then we have the behavioral and psychological symptoms, and these symptoms are a heterogeneous group of affective, psychotic, and behavioral symptoms, and they appear in up to 90% of people living with dementia. So they are amongst the early signs and they fluctuate. So they can occur in any course of the illness and they will come and they may go. And we know that as the course of the disease progresses, their severity also progresses and their frequency also progresses. It's important to know about BPSD and to treat it because it has serious complications, not just for the patient, but for the whole care unit. So with regards to the patient, things like risks of falls and fractures, and they also are associated with a high risk of caregiver burden. And it leads to high levels of hospitalization and also increases the risk of institutionalization. So it's important for us to know about them, screen for them, and know how to manage and treat them. So with regards to the pathogenesis, it's complex and it's an interaction of multiple factors that impact directly and indirectly on the disease process and on the person. So biological factors, so there are many causes for dementia, Alzheimer's being the most common, followed by vascular, but there's also other common causes such as frontotemporal dementia as well, and dementia of Lewy bodies, and then other causes that are not as frequent and also frequent in our setting, that being HIV. So it's the disease process itself. So neurotransmitters, neurobiological factors, neurochemical factors, and then also biological in terms of comorbidities. And then also treatment that patients are on, which is very important when we're taking a history to know about the comorbidities and the other treatments that patients are on. Also psychological factors, so such as the person's pre-morbid personality and then their reaction to stress. And then social factors such as environmental changes or the environment itself. And then also caregiver aspects also play a role in the symptoms. So there are varied symptoms, and certain symptoms are more specific or more prevalent in certain types of dementia. So psychotic symptoms are common in Alzheimer's, and then also visual hallucinations and Lewy body dementia. And then vascular dementia is associated with things like apathy and depression. And then we know with the frontotemporal things of personality changes yeah. So they can occur in any of the dementias, but it's important for us to know the type of dementia and then be on the lookout for symptoms that may occur in those types of dementias. So how we manage them, or an approach to management, is, so like a caregiver or patient may come and say, so maybe the caregiver can give a history that the person was aggressive. Now, aggression on its own, it's not enough for us to know the cause or for us to manage. So it's important to look at a symptom from a patient consideration, the caregiver, and the environment. So looking at the patient, what exactly was the behavior and what did the patient perceive to have happened? And how did they feel about it? And then it's important to look at risk throughout. So risk to the patient, risk to the caregiver as well. And then with the symptom, how much distress was it to the caregiver? How did they articulate this and what did they do before and after, and then look at environmental considerations. So things like a change in where the person was living. Also look at who was there, who was around. What time did it happen, and did it occur in relation to other events that were happening at the time? Like, was the patient eating or bathing, and where were they? And then to investigate why. So with looking at the patient, sometimes it happens that a patient can be treated by multiple clinicians or multiple specialities at different places. And there could be treatment modifications that you may not be aware of. So it's important to ask about recent changes in medication, but also to ask about pain. And as the dementia disease progresses, patients may lose the ability to articulate their concerns and their needs. So it's important to rule out pain and see if there is pain that is not being treated. And then also screen for medical conditions as well. And then, is there an underlying psychiatric comorbidity that is not being managed? And then the severity of the cognition, look at sleep, sensory, and then look at, is there a fear, sense of loss of control as well? And then the caregiver's understanding of dementia, because sometimes the caregivers don't understand what dementia is. And it's important to know about their expectations of the condition. So do they understand what's happening? Maybe the caregiver has changed, or maybe since the disease is progressing, the caregiver wasn't given or maybe told adequately about what should happen. So it's just to highlight that at every opportunity that we have with the caregiver when we're seeing them, that there should be continuous education and management of expectations, but also see that there is no stress, caregiver burden, or depression from the caregiver side as well, and then look at the symptom in the context of the family, and then also look at the environment and daily routines. Is there understimulation, overstimulation, and is there now a lack of activities that the patient enjoys now being done? So when it comes to treatment, non-pharm treatment is the first line, and it's important to have an MDT approach or MDT care when it comes to management of people with dementia. You need to measure the symptoms before and after and have achievable goals. So if the person was not sleeping at all and you're currently doing an intervention, your aim should be realistic about how much change you will get. So, and then managing the expectations of the caregiver and the person with dementia. And apply the intervention consistently. So non-pharm interventions need to be applied consistently, and then there has to be constant skills training of the caregiver for them to be effective. And then we also need to continuously evaluate the plan and think of alternative strategies as well. So there is some evidence base for non-pharm treatments, but the studies, there haven't been a lot of studies, and the evidence for some of them is not as robust. But some of the studies have shown that increasing meaningful recreational activities that match the person's previous interests. So asking someone to do something that they didn't previously enjoy or didn't like or do before may now give you a poor outcome of what you're trying to achieve. Also, music matched with the person's interest can reduce agitated behavior. And then one-on-one attentive care or contact can reduce disruptive behaviors. So things like this are important to implement, but also look at the person and also look at the caregiver and the setting, so that you can see whether with the intervention not effective because of the intervention or because of how it was done. And things like physical activity also lift the mood. So environmental interventions in residential settings. So things like providing a home-like environment and then avoiding over and under stimulation. And this is also for people that are still living at home. So sometimes someone gets a dementia diagnosis and then they are, because of fear of wandering or fear of stigma, they are then in their room and they don't go out, they don't get any stimulation. So those patients will be agitated and present with BPSD. And then overstimulation of where things like clutter, a lot of noise, where the person then feels like they've lost control. And then adequate spacing and privacy. So the evidence base for the caregiver intervention, so skills training resulted in significant reduction and caregiver education. So enhancing support for the caregivers reduces problematic behaviors and then in turn reduces caregiver burden. So it's something that we need to strive for in our clinical practice. Understanding also our limitations. So pharmacotherapy is indicated when symptoms are moderate or severe, have failed non-pharm treatments, and they significantly impact on the person's quality of life or the caregiver's quality of life and function, or they pose a significant safety concern, such as where there's the aggressive behavior or things like wandering. So it should not be your first line. So before you initiate pharmacotherapy, we need to go back to understanding the symptom and the behavior. Does it warrant the drug therapy and why? Is the symptom likely to respond? So not to shoot in the air, but you have treatment goals. What are you trying to achieve? And then which class is the most suitable? And then think about the potential side effects before and look at drug-drug interactions of what the person is currently on and look at how long it should be continued. Because the symptoms fluctuate and because severity fluctuates, you need to reevaluate the patient often so that you can see if there's still an indication or a need for the treatment to be continued. So if we look at antipsychotic medications, so you know there's two classes, typicals and atypicals, and they are commonly prescribed, and there's good evidence based, but there's controversy because of the increased mortality risk and cardiac adverse effects to it, and risperidone is approved for use in the UK. So there was, looking at the CATI trial, where they looked at atypicals, they found that risperidone and olanzapine are the most effective. For risperidone was up to 1 milligram and olanzapine up to 7.5. And the symptoms that were likely to respond are aggression and psychosis, but the adverse effects offset the advantages. So these patients are elderly and they're already vulnerable, and they also are on other medications. So they are high risk of adverse effects such as EPSE. So it's important to monitor these patients and only prescribe the medication if necessary. If looking at antidepressants, so SSRIs are considered as the first line for depression and then agitation. And there have been multiple studies on depressed subjects. The evidence for efficacy is poor, insufficient, but there's limited efficacy due to the profile of patients that have been included in the studies. So that's another kind of rate limiting factor, that there haven't been as many studies done, but SSRIs can be considered as the first line. Mood stabilizers are generally reserved as an add-on treatment, but there's limited efficacy and there's high rates of adverse effects. And some of the RCTs have shown that they're not statistically significant benefits that were seen on them. And as I said, there's high risk of adverse events. So when thinking about them, that's one thing to consider. Benzodiazepines are commonly prescribed, but the studies have shown short-term efficacy. The acting benzos are preferable. There's recently controversy over long-term benzo use and cause or increased risk of dementia. The other concern with benzos in these patients is the side effect profile. So things like confusion, sedation, and ataxia and falls. So the principle then is to restrict to short-term use only if needed and short-acting versus a long-acting benzo in these patients. The cholinesterase inhibitors are used off-label, and the specific symptoms that can respond are apathy, motor behavior, hallucinations, delusions, anxiety, and depression may improve. And there's some evidence that rivastigmine may reduce hallucinations in DLB. There's also been concerns of withdrawal, that the withdrawal can lead to reemergence of the BPSD in these symptoms as well. And this is, I'm talking about symptoms for non-cognitive symptoms of dementia, so BPSD. So the key points about management of BPSD is define your target symptom or syndrome. What exactly are you treating? Because that will inform how you go about your intervention. For all the medications, start low, go slow, and monitor side effects frequently. And the best practice is to integrate the pharm and non-pharm approaches when it comes to management of BPSD. I know I went through that really fast, but I'm happy to share the references and resources with everyone after this. Okay, now moving on to GBHI. So I was an Atlantic Fellow from September 2021 until August 2022. And I was an Atlantic Fellow as part of the GBHI Institute. So GBHI is part of the Atlantic Philanthropies. And the gentleman you see there is Chuck Feeney. Chuck Feeney made his wealth from the duty-free stores. And in 1982, he joined a movement, or he decided to give while living. So he invested all his wealth, or most of his wealth, in Atlantic Philanthropies, with the aim of equity being the cornerstone of all the programs. So there's 7 programs. I was in equity and brain health, but there's racial equity, social health, economic, and they are all over the world. And there are 683 fellows. Yeah, some of the programs are in person, some are certain parts of the program in person, but they all speak together at the end, but they're all done separately during your time as a fellow. So how the fellowship works is that it's divided into like four stages. So our fellowship, the aim of it is to look at ways of improving brain health all over the world, looking at different approaches to improving brain health. So the cohorts, or the people that get selected and apply, are not just clinicians. Our group had, I think there was one site, we had a cluster, it's in 2 sites. So our site was Trinity Dublin, and then there's a San Francisco site. Our site had 12 fellows from all over the world. There was psychiatrists, neurologists, scientists, community activists, service design people, playwrights, researchers. So it's different sectors, but looking at how the different sectors can all have an impact on improving brain health. Also looking at the fact that there is no cure for dementia. So we need to look at other ways towards improving quality of life and making an impact on improving brain health. So our program is a 1-year in-house program. So you are those that are in San Francisco, and we were in Dublin, but the 2 groups meet. So one big class And we then meet twice a week as the big group, and then we also have site-specific things. So the aim is that you are developing an intervention or a research project for you to do in your region or in your country when you go back. And the research project is about how you can improve brain health. So depending on where you're from, depending on your working background, so you decide what you're going to do, and you work with your regional mentor. So your regional mentor is your mentor from your base, so your South African mentor for me, and then you get assigned a mentor in the program that is kind of aligned to what you're doing. So my mentor in the program is a geriatrician. And you then start brainstorming what project you would like to do. And then throughout the program, you are working towards the protocol. And then you submit it just before the program completes. And then you kind of wait to hear about whether you get the funding or not afterwards. So the program has different facets. So there's parts, so there's like there's classes where the modules are different. There's brain health stuff, so like biology, neuroanatomy. And then you also then get the creative part. There's also about how we get taught about creative interventions for brain health. You get taught about health economics. So what exactly that looks like, and basically the basics of it. And if it's all of these, if it's what you are interested in, then you can take a deeper dive with that faculty member afterwards. Also about law, also about policy. So it kind of looks at all the facets of how you can make an impact. And then if it's what you like, then like I said, you take a deeper dive. And then there's skills. So like taught how to do things from like how to do a PowerPoint, how to write a letter of intent, how to write a grant, how to write a protocol, and things like that, basically getting capacitated. So working one-on-one with someone that is faculty, and they are kind of teaching you or taking you through how those things are done. So how I think things are better told in pictures. So there's a big leadership component to the program, and it's a way to help us realize that as a clinician or in the area of work that you are working in, you always have the opportunity to make an impact. And then also leadership skills. So there's small group sessions where there's 4 fellows and there's faculty where you're discussing things around so topics like self-awareness, self-mastery, resilience, going through different leadership dilemmas and discussing them as a group. And having tasks basically that push you and kind of doing a lot of introspection and then like a way forward as to how you're going to carry on post the program. There's a big clinical and lived experience. So this part is about getting exposure to the clinical part. So basically how the hospitals in that area operate. So as a psychiatrist, I spent a lot of time in their memory clinics, their psychiatric units, and basically seeing how their day-to-day is run. I joined a lot of their MDTs as well, but also getting exposed to resources as well that you can then take and adapt, and programs that you can then take and adapt to your local setting. Also spend time in things like care centers. So spending time with like architects and designers, because there's a big push now towards dementia-friendly communities. So things, well, looking at the center, kind of how do you design the center, the lighting, the windows, the color of the wall, where the things in the spaces should sit and should look like. Looking at the activities, what do they do? How do they manage BPSD? How do they manage the patients? How do they manage their caregivers? And then looking at dementia-friendly communities. So making transport systems dementia-friendly, making housing dementia-friendly, making shopping centers dementia-friendly, cab facility, cabs, buses, how do you then make those spaces dementia-friendly so that people living with dementia can function independently longer, but with the support of the whole community, which decreases the burden on the caregiver and gives caregiver respite. And then also spending time with people living with dementia. So the photo at the bottom, the gentleman in the middle is Kevin, who has Lewy body dementia. And he's written books, he's on radio stations, he's part of research teams. He does a lot of advocacy as well, things like the Alzheimer's ADI conferences. He advocates a lot and is like the voice for the person with dementia in the spaces where we are designing interventions for dementia and designing research, but without the voice of the person living with dementia there. So we did a lot of that. So there's also patient and public involvement. So in the Global North, most of the grants will not give you funding if you don't have someone or a person with dementia in your research team. So not just as a participant, but as part of the research team from the research question development to the study design. So basically giving insights and being the voice for the person who will be the participant to see that your study will be impactful, will it be feasible, will it be strenuous on the person with dementia. And there's advisory panels where people with dementia will advise research teams on what they feel about the study or the design, and yeah, so they're very active on the dementia space, and we're currently working on a toolkit to see how this could work in LMICs, but also to a toolkit to inform researchers on how to practice PPV or PPI in your research project. And then there's also a lot of creativity and brain health stuff. So there's a lot of creatives, there's artists, musicians, but looking at other interventions, so non-farm interventions for dementia care. So things like choirs that they also ran even during COVID, where they would meet and sing via Zoom. But that being a way for social engagement, because high risk of loneliness, which has adverse effects on dementia and leads to poor outcomes. So looking at how you could adapt an intervention like that into your local setting and what it would look like. And things like arts interventions, music interventions, looking at the limitations that we have with pharmaco treatment and the fact that non-farm should be done first. There's also a lifelong fellowship. So I am now a senior Atlantic fellow. So after the program, you become a senior fellow. And as a senior fellow, you are then now part of the whole Atlantic philanthropy system. And you meet with fellows from other programs, and there's a lot of funding available for collaborative work. So for instance, if there are 3 of you in South Africa, or 3 of you, like in KZN, there's 3 of us and 2 other people in other programs, but there's funding if we were to apply for funding to do a project here, there is a pool that's kind of forces you to collaborate and work interdisciplinary for towards a research project or a study. And we meet often. So yearly there's a conference where everyone meets, and it's a way to network and collaborate, and for people to give updates on where they are, and then a lot of also looking at what studies have people done, what interventions have they done, and can you take those and adapt them to your local setting as well. So you are a lifelong fellow for GBHI. That's why we still are working together and still have projects and conferences coming up. So I'll be brief now. What is my GBHI journey? So if we look at the challenges in dementia management in South Africa, there are multiple. So we know that there's low dementia awareness and there's stigma surrounding the disease. And those things lead to poor outcomes from people delaying to present, because of not knowing and because of the fear of the stigma of the disease. And then also people living with dementia being at risk of violence. And those are things that we've seen. We also don't have a dementia strategy or policy. I think they're still in the preparation. I think there have been some issues now with that. So because we don't have something like that, it speaks to the fact that the services are not well resourced, and the services don't speak to each other. So health doesn't speak to social. There's no clear MDT approach or policy. And then also dementia training of healthcare professionals. So it's not something that is done routinely, and that then impacts on the screening of patients, identification of patients, but also on the management of patients with dementia. And we know that there's a paucity of dementia research. So like I said, the output or the outcome should be that you have a pilot project from your, that you're going to implement in your country going forward. Yeah, so for me, I looked around the cultural stigma. So it was something for me that was, I think, important and something that I wanted to kind of look around how we could impact, because that also then speaks to awareness and then speaks to poor outcomes and speaks to risk to the person with dementia and their families. So there have been studies on cultural stigma and traditional healer collaboration. So they've shown that up to 84% of people with different ailments do present to a traditional healer during the course of their illness. And they've looked at, is it accessibility or preference? So there's a study that was done where they showed that people with snake bites, it took them 30 minutes to get to a traditional healer, but it took them 8 hours to be seen and to get to a emergency unit to be seen. So looking at the problem with our resources, this is a system that we can leverage on, and looking at effective coordination between the systems. Not really, I'm not looking at the treatment per se, but we're looking at screening, patient identification, and basically education and improving awareness. And there have been previous studies that have been done in other parts of Africa, looking at traditional healers and dementia care. And the traditional healers, they didn't conceive dementia as a specific disease, but they thought it was just symptoms of normal aging, but they expressed a willingness to collaborate with services. So our project is looking at co-development pathways, and I can see some of my collaborators are on. Yeah, so that's where we are. And post the program, now we know that we got funding, so now we need to start implementing the project. So lessons learned, I think mentorship was, very important for me. I think it was, one of the biggest things that has kind of led me to where I am in my career. So I'm really grateful to have great mentors. And then collaboration. So the program, a lot of it is about collaborating and networking. So we can do a whole lot more if you work together. And there's a lot being done. It's just about reaching out and not having to restart things, but there's so many things that you can take and adapt. And when you collaborate, there's more you can do, and you are exposed to more, and you have a bigger reach. And okay, I'm not going to get that stuff, but thank you. Happy to take some questions.
Yeah, thank you so much, Khanyo. Great talk. So you can feel free to raise your hands, and there are hands up already. So let's start with those, and then I've got a couple of questions as well. Thank you for finishing nice and early, and so that there's enough time for us to engage in the Q&A. Dr. Mafuze, do you want to go first?
Thanks, Prof. Thank you, Dr. Ngcobo, for that exciting and interesting presentation. My question is around, looking at very bad conditions whereby non-pharmacological and pharmacological options do not work. Did you perhaps come across during your time there, or any studies where if you do ECT or deep brain stimulation, does it improve the BPSDs?
So there have been some studies looking at ECT and looking at depression. And they say if you have failed non-pharm and pharm, you could do ECT, but the risk is that there's a high risk of delirium post the ECT, which is then a limiting factor. But also, I think the important thing is to always go back, right? What exactly are you treating? What is this BPSD that is not improving? Because there's so many symptoms, but unless you know the cause or you've kind of explored the symptoms properly, it's difficult to say you've failed, But it's very difficult to treat the patients because there's a lot of, for non-pharm to work, you need to have the buy-in of the care partner. And if there's no consistent buy-in of the care partner, then your interventions, there's a high chance that they won't work. But then also looking at our setting, like our real life setting, caregivers often change, the settings often change. Someone will be moved to stay with another relative because this relative now needs to go work. So you're going to keep getting BPSDs, and it's going to be like what you're doing is not working. But there's going to be a problem because you keep changing the environment. And also, if the person, I think a big flaw in our system is that because our services are so under-resourced, it's difficult for caregivers to get continuous support. And when caregivers don't get continuous support, continuous education, then the caregivers themselves can't really be a good part of your treatment intervention. So yeah, that's the long and short, but I'll share the resources, but they have used ECT in depression, but it's just the high side effect profile afterwards and the delirium.
Thanks, Khanyo. I think Dr. Mafuze, like a typical doctor, wants a bullet, things that we can use just to solve the complex, and these things are, as you rightly said, are very complex. And yes, sure, certainly stimulation might be an option, but perhaps we should be looking at it much more broader. Dr. Dawood, do you also want to ask Khanyo a question? Bilkish?
Thank you. Thank you very much, Dr. Ngcobo. That was a really good presentation, and it's very
Apologies, Prof. I thought it was our Bilkish in our department. Apologies.
Why, do you not want to talk to me now?
No. Of course I do. Of course I do. That's why I said, Dr. Darwin, I promise. It was a mistake. Please go ahead, Prof.
Not a problem. Just thank you very much, Dr. Ngcobo. That was really an exciting presentation. I think we're really excited to know that this kind of expertise is now available in our sphere. I think you're quite aware that we run a multidisciplinary memory clinic at Nkosi Albert Lutuli Hospital, and we have social workers and neuropsychologists as well. But one of our big problems is getting the softer side. We're not talking about medications because nothing really works as far as dementia is concerned, but talking about all the things that you've just spoken about. And I think it'll be really nice to be able to collaborate with you on those aspects. We have great difficulty with caregivers, with legal issues, financial issues, and those kind of things that become so important for patients with dementia. We also work with the Bessie Makatini Foundation, who I see are one of your collaborators. So it'd be nice to have a wider collaboration. And I'm sure Dr. Ahmad, who is in charge of the memory clinic, will contact you herself. But we'd really like you to be part of our memory clinic and come and add to the work that we're doing. And I'm sure you're going to have a great contribution. Thank you.
Thank you so much, Prof. I'm actually gonna trouble you, soon. And there's another study that got funded that's gonna work with BMF as well, which is great. Where they're looking at Voices for Hope, so empowering people with dementia to advocate for themselves. So with that project, we can definitely leverage ways that we can work with you, and there's other research opportunities that we have available and other funding. So definitely, I will definitely reach out to you, Prof. And there's a lot more that we're still gonna do. And we have a lot of buy-in and interest in South Africa, so we definitely gonna carry on doing some stuff.
Yeah, thanks, Prof. Kasem. Thanks, Khanyo. There's a question in the chat from Tabo Magwai, who's asking about the fellowship now and the collaborations after the fellowship, and whether they are specific to dementia or any brain health related issues.
Okay. So the collaborations with other fellows from the other groups, is that the question?
Yeah, Tabo, do you want to unmute if you can and speak to your question?
Thank you, Prof. Thank you, Doctor. I was just asking if the collaborations, can you do them with the just fellows, or you can do them with anyone, even if they're not a fellow? And if you can do it with those that are not fellows, is it specific? Does it have to be specific to dementia?
No, so the first part is, for us to get funding, there has to be another Atlantic fellow that applies for funding with me. But whether we can work together, we can, because you could be a collaborator on a project that I am working on with another fellow that we've gotten the funding for. And it does not have to be dementia. So our project was dementia, our program is dementia, but I mean, the people I'm working with were part of health equity and others were social equity. So if we want to do something on maybe GBV or something like that, we could do it, because when you look at brain health is basically from womb to tomb. So brain health can be, you could spin it whichever way. So there's opportunities. So I'm happy to collaborate if people want to do work. There's funding available, but we need people that come with ideas that will do the work. There's funding available, but and happy to take collaborators. But you could still apply if people wanted to apply. I think this application is closed, but there's an application next year. And you can just reach out to me and I can give you the information if you need it.
All right. Thank you very much for the information. I will definitely be reaching out. I'll just get the contacts and I'll reach out. Thank you.
Okay.
Thanks, Khanyo. Ngcobo is one of our PhD students in neurosciences, so I think it's also appropriate for this kind of fellowship. As you know, and you're aware that mentorship is obviously one of the things that we really encourage in this department, and we really try and make sure that people are mentored. And I'm not going to ask you perhaps right now to talk about your mentorship fellowship because you've already spoken about it, but I was wondering, there is Dr. Ngcobo is also on the call. I don't know if Tube can say a few words about her experiences, because I'm aware that she's a mentor of is it an artist, Khanyo? Which might be interesting because we usually are used to mentoring doctors and psychiatrists. Tube, are you able to speak to that?
Maybe while she's coming on, maybe I can share my experience. I think
Sure.
It was definitely hard. I think a lot of people struggle. I think I was just blessed at that. I found a perfect fit, even with my mentor that I was assigned. Because there are people that struggled, especially interdisciplinary mentorship is very difficult. In academia, I think we have a different way that we do things as opposed to someone who is in the creative space. So we basically started working on the project from the day we walked in. Now, other people that were creatives kind of struggled with having to do one thing for a long time. And I think that then also was also a challenge in how how their mentorship experience went. But I think for me, it's about finding someone where there's similarities around how you work and what you do. I think it made it a bit easier. I think the people that struggled with us were people where it was a different field, where they're not used to academia and how we write protocols and how we sit every day and do work on a project for like 4 hours. For them, it was like, we can't do this every day. So I think it's about finding the perfect fit. So finding a mentor that aligns to what you're doing, but also aligns with what you want to do or trying to do.
And then maybe last question from me, and then we'll have to wrap up, unfortunately, is about, I guess part of what we try and do is to showcase what Africa can bring on the global stage, right? When it comes to research, when it comes to this kinds of work. And I imagine when you were there, you're representing us. A lot of the work, though, is usually around sort of some of the cultural stuff, Ubuntu, some of the social cohesion stuff, which I think is important. But I was wondering if your thoughts about some of the biological contributions Africa might have. So, for example, antioxidants from rooibos and plants like that, or relationships with other things that we are able to perhaps give. Is there any work around that kind of area, trying to look for contributions in that part of the field, not just in the cultural side of things?
In our program, that's it. No one has done that. But I think it's very open. There just needs to be someone who wants to do that. Because even if you look at my project, I am the first person to look at indigenous healers in the care pathway. And when I started, you'll know there was a bit of resistance because it was very novel, and it was kind of like, why am I not doing screening tools? So it's about if people present that and they have support with that, then they would do it. Then I think there would be buy-in. For now, though, there's an Africa consortium which is looking at kind of dementia in the African space. So they've put together a paper now, and then the next step is then to look at locally appropriate dementia interventions in the different regions in Africa. So if someone was interested, that would kind of be then where that would go off.
Sounds very good. Thank you very much. That's actually now, it's 1 o'clock. So I want to say thank you so much, colleagues who've joined in. And I'm really glad to see people from outside of psychiatry, and Prof. Kasim and other colleagues would appreciate that you've joined in. And I'm sure Tube and Khanyo and others who've been involved with this will be happy to be willing to collaborate. So looking forward to many collaborations around the area of brain health. So thank you so much, Khanyo, for giving this fantastic talk. Have a wonderful day further, colleagues. Thank you.
Thank you, everyone. Thanks, Prof.